Hi, good morning and good afternoon, everybody. I'm Jim Malpas, Leadership Programs Director for Health Leaders Media. I want to thank you and welcome you to our program today. We're privileged to be live at Baylor Scott & White Health in Dallas, Texas, in the Charles A. Sammons Cancer Center in this wonderful auditorium. And I want to thank Baylor for hosting our program today, and for our CEOs, Dr. Joel Allison and Dr. Bob Pryor, for their time this morning as well. Just a couple of notes about our program before we get rolling. For those of you who are watching on screen, please go ahead and if you may notice on the top right of your screen, top center of your screen, there's a little button to enter our chat room. Throughout the course of our program today, we're going to be able to take questions from those of you who are watching online. If you do, just go ahead and enter it says live Q&A. Go ahead and enter that, and one of our senior editors, Jacqueline Fellows, is here to moderate those questions and be happy to introduce those throughout the program. We're not one of those programs who saves them all to the end. We try to get them in when we're talking about the subject at hand, so we encourage you to participate in that. Our first panel today, one other quick housekeeping note. If for whatever reason you're having a technical issue, you can't hear me or the picture doesn't look right, there's a live support link as well. Just click on that and someone from our team will be right with you, try to get it all figured out. Our topic for today, and I want to welcome our first panelist, Joel Allison, who is Chief Executive Officer of Baylor Scott & White Health, and Dr. Robert Pryor, who is Chief Operating Officer and Chief Medical Officer for Baylor Scott & White Health. On our first panel today, we're really talking about a merger partnership built on cultural fit, clinical alignment, and market growth. Just quick facts about Baylor Scott & White. I think this is the combined entity here of the legacy Baylor and Scott & White Health Systems, but you get the picture, it's big. 46 hospitals, more than 36,000 employees. And I want to go back, and we've been fortunate to work with both what was Scott & White and Baylor on these types of programs before. And for those of you who participated in this program, the case study that was published along with it, this quote from Joel, is in that case study. And I like to put that up there because I think, Joel, this really sort of sets the tone for really the vision. And if I could get you to go back, pre-merger, and I guess at this point, talk about it from the legacy Baylor's perspective of what you were looking for.
Good. And welcome, Jim. It's our privilege and pleasure to welcome you and health leaders to the Baylor Charles Sammons Cancer Center, and I want to welcome the live audience and those that are joining us by technology across the country. Welcome. We're happy to have you with us today. We're very excited about sharing our story, Jim, and it really goes back to the fact that you have two organizations, and looking at it from Baylor's perspective, specifically 112 years of service to our communities. We have been very much a health system focused on patient care, on how do you make it better for the patient, focused around quality and safety, and wanted to continue, though, to grow, make sure that we're meeting our mission. And one of the fundamentals that we have is we have four very strong pillars for our mission statement. It's around patient care, community service, education, research. And as we saw healthcare beginning to change, and what we want to do was be obviously one of the leaders in transforming that, one of the great relationships that we've had in the past is working with Scott & White. And we've been in different coalitions together, working together. Our teams have worked together on best practices. We were the only two, and still now the only systems in Texas that are members of the High Value Healthcare Collaborative. So we had a lot of synergy, and Dr. Pryor and I had worked together looking at how we could improve healthcare through our coalition, Healthcare Coalition of Texas. Well, as Baylor was continuing to grow, we saw that we needed to grow. Texas was growing. We knew that if we really wanted to move to the next step, which we felt was around population health management, we'd adopted the triple aim. Our team had really felt that this was the future, and we really wanted to focus on patient-centeredness and really meeting the needs of the communication, but also moving to a wellness prevention model as well as a sick care model. We knew we had to get bigger to do that. We had to have a larger footprint. Healthcare was headed in that direction, and so we started talking in our conversation with the board of how do we grow. And we felt like we truly needed a partner, but we knew we needed the right partner. And we also knew, as part of the Baylor strategy going forward in our strategic plan, and talking with our board, we knew that more and more risk was going to be put on the providers,
right,
by both employers and the commercial payers, as well as what we were already receiving in risk from the federal government and state government. But we knew we needed a financing vehicle. And so as we looked at how do we do that, that led us to the conversations that ultimately we said, if we were going to partner with someone in the state of Texas, who would that be?
Well, and I think the phrase here, becoming a statewide presence, was key. You know, I think I've heard projections that the Dallas area metroplex, the projections for population over the next 10, 15 years are staggering. And you know, obviously Dallas is a large healthcare market, very competitive one. How key was it for you to sort of move that footprint as well, and not, you know, get out of the metroplex, right, so to speak?
Yeah, and that's a great point, Jim, because we felt like we had to become almost statewide if we were going to really be able to do population health management. We needed a larger population to serve because our market is very much consolidated now in the Dallas-Fort Worth area, and it's very competitive. So knowing that we wanted to grow and how did you grow, how would you grow, we had to do it with a very strong, quality-oriented partner that would give us a bigger statewide footprint so that ultimately we'd be able to take risks for a larger area and also for those employers or commercial payers that need a broad network.
Sure. And Dr. Pryor, from you know, Legacy Scott & White's perspective, and I think we talked before, Scott & White is so unique. I always said it's almost as if they took one of those great you know, Midwestern clinic model systems and put it in Texas, where you know it's so the healthcare market's so otherwise wide open. But talk a little bit more about, you know, stepping back a little bit. What was Scott & White's vision of how this would work?
So we were in a growth mode at Scott & White. We had been in Temple, Texas for 110 years, and then we started moving out into the Central Texas landscape. And in some of those areas, we had actually more cows than people. So when we started looking at population health...
But you don't care for them. You're not at risk for them, right?
They're not at risk yet. This is Texas. But we started looking out over what is the difference of getting bigger and getting better. And that's been one of the things that we started with our Scott & White growth strategy, was to get better. But then as we looked, how do we get better even still? And one of the questions that we asked our physician leadership and our board leadership was, if there's anyone in the state of Texas you could merge with, who would that be? Right. Only one answer came up. Baylor was the only one that would work. Both institutions over 100 years old, both with similar mission, vision, and actually, as we'll talk a little bit later, the cultures were alike.
Right.
But there's one thing that I think that people were concerned about with the merger, not us, but I think external people, is that Scott & White was a clinic model where we had physicians who worked in a clinic, and the hospitals kind of came along after the employed clinic doctors. And then Baylor was a hospital focus that also had physicians. But we came to the same place by two different starting points. Mm-hmm. And I think a lot of people said, well, they'll never pull that off. You can never get a group practice that has been very physician focused to come into a larger organization. That'll never work. But actually, I can say now that after 11 months, we feel like we've actually pulled that off.
Both of you touched on something I want to follow up on, which is this notion of scale. Scale brings the ability to do, as you say, population health well. It's a theory that a lot of CEOs are testing, whether it's Mike Dowling in North Shore or Peter Fine at Banner, that scale is going to give you the tools and the depth to be able to, as you say, make population health work. How critical was that for y'all, that you really did need to get that size or that growth to be able to, I guess, have the team that's going to translate all this and put it together?
Yeah. You make a great point. And what Bob said, scale is important, but big isn't necessarily better. Better is better. So it wasn't about just getting bigger. It was how do we get better at what we do, and that's taking care of patients. But we saw also that scale would allow us, one, to achieve our vision around population health management. It also would allow us to become more efficient. It would allow us to have better access to capital. And it would allow us, I think, to have the necessary resources to continue to fund our mission. That's very important. So I believe as we go forward, we're going to see scale become more and more of an important need for large systems to be able to meet their vision around the patient. But again, I would just emphasize what was said earlier. Big isn't necessarily better.
Yeah.
Better is better. Never lose sight that we're here to take care of patients.
If I just might add,
Yeah.
once you start thinking about population health, you realize that population health term is too broad.
Right.
And we could do population health in Temple, Texas. We could take care of a defined population in a small Texas city. But as you start looking at what you mean by population health and you start defining those populations. So number one, we have a population definition of who is part of our health plan. That's a population. We have another definition of who lives in our communities. That's a population. You have another population as who outside of our region want to access our services, and how would that happen? That's another population. So while you can actually take care of a limited population with a limited scope, once you start defining the populations that we're going to take care of, then that scope has to grow. So for now, I don't think there's any clinical entity that a patient or a community member would have to leave Baylor Scott and White to get. We're totally comprehensive.
Right. And we'll talk a little bit about, in our last panel, obviously, we're going to spend a great deal of time getting into more detail about the clinical integration work. Let's talk again about the timing, because you both touched on it a little bit. And again, I think this is so key. And Dr. Pryor, I think you even said in the course of the case study, Scott and White was in a position where you didn't have to seek a merger at that time. It wasn't. It was important, but not. You didn't have a burning platform, or the foundations you had were solid. So you were in a position to be choosy and find the right one. But if you could talk about, why now?
So while it's true there wasn't a burning platform, what we did see on the horizon was the thunderstorm that was going to bring the lightning that was going to ignite the platform.
Okay.
So while the platform wasn't burning, the storm was coming. So when you look down into the future and say, my job and our job is to create that organization that can respond 5 years down the line. But if we can't wait until 5 years down the line to make the changes, because that's going to be too late. So while it's true there wasn't a burning platform per se, there was a compelling reason to position the organization for success 5 years, 10 years down the line. And that's why the merger became so compelling.
Joel?
Yeah, and that was the same with the Baylor healthcare system. We didn't really see that we had to do something right now.
Right.
And in fact, as you saw in the case study, I think Bob and I, both when we took it back after we talked about it ourselves to the chairs, they didn't see any reason. In fact, they said that's the stupidest ideas we've heard. So there wasn't a lot of real enthusiasm at the time from our chairs and the boards to do this, because we had been successful. Again, we're over 100 years old, both of us, and so we were continuing. But they said, why would we want to do it? And that's when we started talking about the fact of what we need to do to grow, to go beyond the region, to really start looking at this growth of a statewide network. And that's when we said, this area is consolidating. And we're seeing national players entering the market. So we knew we were going to have to really grow. We were going to have to get a partner. It wasn't a sense of urgency, but as Bob said, it was right there in front of us, and sooner or later it was going to happen.
Do you feel like this, the timing, part of the timing was, obviously the market, that there is while it's not an explosion, there is a growth in at-risk contracts, that you're out there, you're more able to put together, again, statewide types of products where you can go to major employers, just commercial payers, not just from a sort of, overall perspective, but from a business and market perspective of bringing those types of products out. It seemed like the timing was you're right in there, if not a little bit ahead of the curve.
Right, yeah,
to be able to deliver those.
And timing is everything, and we felt it was the next step, and to really be a first to the market to do something of this scope in our area, in our state. So, yeah, the burning platform wasn't necessarily there, but we knew it needed to happen.
Let's talk about the physician models, and Dr. Pryor, you touched on it. Scott and White Legacy is a clinic model, as you said, started as a physician-led enterprise. Hospitals came later. Baylor, more sort of traditional health system-based type of model. And others across the country sort of struggle with how those two would come together. Talk a little bit about that, because I think, again, Scott and White is somewhat unique. There aren't that many clinic model systems left, and they tend to be concentrated in very particular areas. Were you worried at all, from your perspective, Dr. Pryor, that you would lose some of that history and culture of what you had built at Scott and White in this whole process?
That was a worry of a lot of people, but I really had less worry because of our long history of our physicians working together. Mm-hmm. And when it comes right down to it, it doesn't really matter how a physician gets their paycheck. What really matters is what's motivating the clinical processes that take care of patients. And these were very similar. Mm-hmm. Even though in many instances, Scott and White looked a whole lot different than the Baylor physicians. But right down to the core, there were very few differences in mm-hmm. how and what motivated the physicians, which is good clinical care.
Mm-hmm. Right. Yeah, and I agree with that. And if you look at Baylor's history with our growth, as Bob said, but in 1994 we started employing physicians.
Right.
And we also have a history of where we have worked very closely with our physicians. Mm-hmm. Excuse me. And what we had been offering is kind of a menu of options on how physicians could engage with us, because what we wanted most of all was that physician engagement, mm-hmm. to where they were helping us with our clinical excellence and leading. Mm-hmm. And so we'd had a history of working very closely with physicians. And as you've seen over the years, our employed physician group has continued to grow, and we will see that continue. But we also still have other ways. And it's important, I think, at the end of the day, is if you're going to be truly what we are now and fast becoming even more refined at, is an integrated delivery system, it's physician engagement. Right. People talk a lot about physician alignment, but I think now we're talking about physicians engagement where they're taking an active role, and mm-hmm. you'll hear more later in the panel, other panels, about how we are very, very effectively and actively engaging our clinical leadership.
Sure. And Dr. Pryor, the thought, and maybe I don't mean to overcharacterize what Scott and White. Scott and White is very diverse, had worked with independent physicians as well, and obviously had that relationship. How, if anything, does it change the sort of view of your physician in terms of, because it is, you've got this more sort of open model that works that Baylor's bringing into it. Does that create other opportunities for new directions for the sort of legacy Scott and White physicians as well?
It creates a lot of opportunities. One of the things that when this was talked about at two levels, one was our existing clinic board of directors.
Yeah.
One of the things that they realized, because of the history that we had of working together, was that this was going to augment our ability to practice medicine,
right.
not diminish it from it. One of my most frightening meetings I had was with the emeritus physicians at Scott and White. We have a large group of emeritus physicians from the clinic that are still very actively engaged in the leadership of Scott and White, and I went to them and I explained to them where we're going, and I don't think I got any dissension that day. They were all for it. Even our leaders that brought us to where we are today were all for it.
Yeah, and same thing at Baylor. Quite frankly, we never had any concerns, or what I was anticipating was negative feedback from our physicians. In fact, we got a lot of encouragement from physicians who are in a variety of models working with us.
And I think the vehicle for making all this work, and we'll talk about it in more detail in the final panel, is the Quality Alliance. And from your perspectives, talk a little bit about what that allows you to do with the physician enterprise.
Well, let me make a few comments, and I want to ask Bob to go into a little bit more detail. But for us, the creation of the Quality Alliance was that mechanism. It was really our approach to an accountable care organization, however you want to define it. And we didn't go early with the Medicare Shared Savings Program at the time, but we will be moving to that. But what we want to do is create a vehicle that would allow physicians, whatever their relationship or engagement with the healthcare system, to help us to become a truly effective quality alliance. And so it was created, and the idea was that whether you were an employed physician and independent physician or in one of our joint ventures or a large physician group, that if you would commit to join the Quality Alliance and you hear more about what's required, then that would allow us to move to the next level of creating a ACO that would be able to go to the market and have a preferred network of physicians, caregivers, and facilities.
The Quality Alliance is what I was talking about before, which is that glue that holds together the physicians regardless of where they get their paycheck, because they align for quality care. And not only do they align for quality care, they get feedback on their practice, and that feedback on the practice compares their practice to where they should be going. And with that data, everybody improves, and really at the end of the day, the patients win.
Yeah. Let's talk, and you touched on this, but this is what a lot of mergers struggle with, is the cultural integration. And you had worked together, as you said. You had a sense of who you were dealing with. Talk a little bit about the steps you went through just to make sure the culture was a fit. But then again, any thoughts on how you had the sense that the cultures would merge together?
Well, again, when we first started talking, and Bob and I were having the discussion, then we brought our senior team in. And when we laid down our mission, vision, and value statements from the organizations, they were almost identical. In fact, it took us about 10 minutes to get agreement around the, quote, new mission, vision, and values for Baylor Scott & White Health. And it was only the fact that we changed maybe one or two words. It was really, that cultural alignment was already there.
Sure.
I think the next step that we did is we talked to our boards and we got into more detail about, how do we know that we can truly say we're culturally aligned? And the board recommended, and we carried it out, we had a cultural assessment. We had an outside party come in and do a cultural assessment. And what was interesting, when the report came back, the organization said, we've done many of these, and this is the first one we've seen where there are so many more alikes than differences. And we know there were some areas where we were not exactly aligned, but we were much more aligned than we were not. And we knew then we could work on those areas. But it was kind of a validation that, yes, these cultures do match. Now, Bob and I'll tell you that it also was helpful, we think, from a culture standpoint, that the two chairs that were working through this with the two CEOs were all 4 Baylor graduates. So there was a little bit of a culture. And the good news was, while we were having these discussions with the chairs, the football team was doing well.
Oh, okay.
So they were in a good mood most of the time.
Bob, from your perspective?
Well, I think that was a summary. I want to emphasize again, I've been in meetings where you spend days trying to get a mission statement together. And the fact that we came together and the whole organization built one in less than 10 minutes kind of substantiated the fact that, wow, these cultures were alike. And I think that was one of the things that substantiated. Now, the other thing that's helped post-merger is that our board has said, we're going to have one. And the thing that they keep saying over and over and over again is, we're not having two, we have one. We have one of everything. And that statement by the board has really helped us in the post-merger to integrate.
Well, and I think that's a key piece. Talk about that a little bit. You could make the case that there's enough geographic distance between the two parts of the enterprise where you could allow for some, of the remaining culture, for some differences or sort of unique pieces to remain. You really did want to go for one culture, which you didn't necessarily have to. It might be the best practice. How has that gone? Because I think you talked about, it's one thing to get the culture put together when the boards and the CEOs are talking about the mission statement, but it's when you get down to the ground of the doctors and the nurses and the therapists all of a sudden working with new people, where it really stands the test of time.
Let me mention one other thing that I think it ties into that, Jim, and I think it was very important, and we haven't mentioned it. Our senior leadership teams that were working on this, and we're from both organizations, very supportive going into it. We had tremendous support from our colleagues and our executives, as well as the medical staff leadership and the board. But one of the things that we did do was we put together a white paper. The teams put together a white paper on why this made sense. And to Bob's point, we now are on that focus of, we want to be one. Since we know we're pretty much aligned culturally, how do we go ahead and implement? And one of the things that we said, couple of pieces to this that I think we need to talk more about on the cultural. One, we always said from day one, this isn't a financial transaction.
Right.
This is more than a financial transaction because there was no exchange of money. The
Sure.
only currency were board seats. We said all along, this is a clinical transaction.
Right.
There's got to be that focus. So are we culturally aligned around the commitment to clinical excellence, which we were. And that helped, I think, a great deal as we moved forward. And I think that was key in the fact that we said from the outset, we're going to be one. And we know that as they did the integration, there's a Baylor way maybe and a Scott and White way. But the other point I'd make is that Bob and I both encouraged them and said, look for that third way.
Right.
Because 1 + 1 = 3. And we may, now that we're together, innovate and create even a better way of delivering care.
What is the Baylor Scott and White way? What is the sort of elevator pitch, the brief description of the way you want the culture to be?
We have 4 non-negotiables.
All right.
You put the patient first in everything that you do, stay true to your mission, live your values, and do the right thing for the right reason.
Sounds like something straightforward to follow.
We want to make it very straightforward. And again, you lead with the patient is why we're here. No matter how big we get, no matter how much technology is around the patient, how many buildings and different care sites, we're still focused on taking care of patients.
And how's it gone? I mean, because again, it sounds like at a base level you had very good alignment with the cultures, but they're 2 very big organizations. Any hiccups, any lessons, learnings, and sort of the cultural merger? Because again, that's what throws off so many of these.
Well, I wouldn't say it's been easy.
Sure.
It's actually been a lot of hard work by a lot of people. The teams have been working constantly since the merger is to have an organization that we can evolve into an innovative organization that's a learning organization. So I think that's the other part of our cultures that I have to point out is that both organizations were learning organizations. So when you put the 2 together, you can actually amplify that learning. And one of the things that some people have asked before is that how did you continue to innovate as you were integrating? And I think that simple statement is look for that better way of doing it. There may be a Scott and White way, there may be a better way, but let's always look for that third way. So it's almost as if we had an excuse to disrupt some things that needed disrupting and go to that third way where neither one of us had the best-in-class way of doing it.
Right. And we do have a question already from someone watching online. How did you have the system in place really to communicate and to allay concern or answer questions about the culture? Because it can't all come to the very, very top. And we'll talk obviously more about this in the next panel. But from your perspective, that I guess you really had the acolytes of the mission well spread throughout the organization to be able to keep the organization moving forward, making sure everybody was on that page.
Well, a couple of things I'll mention. One is that Bob and I did road shows. We went out and communicated directly. Our wonderful media department did videos that we loaded. We created a website for just this process of the integration. So we created some frequently asked questions. So we continue to make sure that it's communicated how far. We realized that was the biggest challenge we had. But it's both face-to-face, it's being visible, but it's using every vehicle in our social media group to do a real effective. The other thing that we're doing as we go along, and some of our people will probably comment on this later, is we do these employee engagement surveys. And we did one a few months back. We do about every 6 months. We've got another one coming up to really see what the feedback is from our own people and how they perceive it's going, and then what do we need to do better.
Let's talk about, all right, so culture fit is one thing. Now you've got to get down to the nitty-gritty, which you really, you have a leadership structure that you need to merge, and this is also where a lot of organizations struggle, because they may try to, it may appear that one is absorbing the other, you lose some local autonomy, all sorts of things can go wrong if it's not done with great care and planning. Talk a little bit about, you must have thought of this very early on, the type of leadership structure you want and how it all came together.
Well, again, one of the things that we did, and as we were meeting with the chairs and then with the board committees that came together to continue that, we determined early on, before we ever got to a definitive agreement or announcing, and we said we want to make some tough decisions first. And I think that was one of the best things we did going forward, was to talk about the leadership structure, the chair-elect, the CEO, the president, and when working through that, we talked about the fact that we weren't going to, the board was definitely going to be equal in the merger. There's going to be 8 and 8 board members from the 2 legacy organizations to create the new board. But as we started putting the leadership structure together, and there were just some opportunities that came along because both organizations at the senior level had a couple of interim positions. Right. There were some openings. So that allowed us then to decide what we're always going to do is get the best person for that position. And Bob and I worked through that, and I think it was very easy to do because we had agreement going in. And I think if you make those tough calls up front, before, a lot of people I know today when they try to do a merger, they announce they're going to do a merger and then they start working on those pieces.
Right.
I think Bob and I would recommend, I think Bob agrees with me, we'd recommend make some of those tough questions. We said, what's going to be the name of the organization? Where's headquarters Service Co. going to be? And you make those decisions for a year, and they actually evolve into the definitive agreement. Sure.
I think the one word I could say that really helps this is trust. If you have trust, then you know that things are going to be okay at the end of the day. If you let that trust slip, then there starts becoming a paranoid element in an organization without that trust. So I think one of the things that is important is that every day Joel and I trust each other. Right. And then we have to tell the people that report to us through, and then the report to them is that, you know, you may come up with a bump in the road, but you have to know that the trust is there to work out that bump if you see one. And I think that's one of the things that we've tried to live, is to say, you know, we understand this is not easy. Right. We understand that you're going to look to the left or to the right, and somebody that used to be there is not going to be there anymore because we're becoming one. But the one thing that we have to do as an organization is, as individuals, is trust that we're headed in the right direction and trust that the right thing is going to be done.
How did you approach the organizational design? Because one of the big challenges that health systems are facing as they get to be this big is, you know, maybe some of the ways they were operating just in a smaller unit aren't going to work the bigger they get. I mean, simply you lose some of that centralization. You have to go to more of a holding company type of model with a lot of local autonomy. Did you feel like you could have to make any drastic changes in terms of how that overall leadership worked, or that you were able to sort of continue with the way Scott, come up with a blend of the way Scott and White and Baylor were leading without having to sort of flip everything on its end?
Let me kind of talk a little bit about one of the things that, 2 things that I think really helped, is that from before day one, we set up 2 committees that were really important. One was called an operations committee that really wasn't an operations committee, but we called it that. It was more of an integration committee, and it was led by Lavone, our chief integration officer, really. I sat at the front of the table, but she really did it. And every week we brought the leaders together to say, we called it an operations committee, but it was really cultural integration, business integration, and integrating that trust. So I think that was important. And then parallel to that, we also built a clinical leadership committee that came together to make sure that both organizations didn't lose our focus on the clinical nature of our company. So the clinical leadership committee actually would pass things on to the operations committee that would further integrate it and put the business together. And I really believe this is why clinical integration happened as rapidly as it did, because we had this direct line from clinical integration into business integration, and it was pulled together with the glue. And again, with the trust factor on top of that, I think that's what made it work.
Let me add a couple of points to that, because when you talk about leadership structure from a board standpoint, one of the things that Baylor had already gone through is that we had one fiduciary board. We have community boards, or advisory boards, and then we have an operations board that kind of oversees the facilities from the responsibility around quality and safety and the credentialing. So we'd already determined to be an operating company. and that's the direction we're going. So, and then the board has been, as Bob said, there's one fiduciary board. So a lot of that was already behind us, and we didn't have to deal with a lot of that. And as I think as we go forward, we're going to ask ourselves, we asked this question of ourselves yesterday, as recently as yesterday, are we structured correctly corporately to carry out our strategies? And I think you have to constantly evaluate that, because we're both different organizations than we were a year and a half ago. I mean, we're both in a different dynamic in the marketplace. We're in a different healthcare environment that we're trying to transform. So I think you always have to challenge your corporate structure, and many times that causes you to challenge the leadership structure.
Going back to one of your original visions for this, it really is about becoming a more efficient enterprise, and that's difficult when you're growing.
Right.
They're almost in opposing force. Has the structure so far been able to drive that efficiency? Have you found that you could combine roles, you could reorganize roles to make the overall organization, to give that sort of unit leader the tools they need to run a more efficient enterprise?
Well, and I think, again, this was another positive when we came together. Both of our organizations were already working on an operations improvement plan, because we both knew that you have the strategy, and I think every system has, break even on Medicare.
Yeah.
So we were already working on operations improvement while we were continuing to grow, and so we had teams working that understood we have to become more efficient. We're going to have to be more cost effective. But I would make the point that part of that is also the clinical effectiveness that comes with it. There's a lot of savings that comes from what the work, and that, as Bob mentioned, you got a clinical integration team working with your operations team. And when you match the finance, the clinical with it, it really is amazing how much more you can achieve.
Absolutely. And we got a few more minutes on this panel, and I wanted to get to the next steps. Really, what is the organization doing to move forward? And I'll let you walk through those, because these came from you guys, again, from the case study. But continuing with the overall system integration, I don't mean to imply that because we're here that we're telling the story in past tense, that it's done, everybody go home, it's all good. It's an ongoing journey.
No, it is. We are on a journey. This is a marathon, it's not a sprint. Because, as you mentioned, Jim, we're continuing to grow as we integrate. So every time we're getting down the path on an integration area, we either have another collaboration or a partner, or we add. So this will continue as we go forward. And I think our commitment is being a truly integrated delivery network. So I don't think you ever stop doing that.
Yeah, I would just add that we've come a long way, and in one instance when we look back, it's like, wow, this was very rapid pace. But I would submit that as healthcare is changing, seems like healthcare is changing more rapidly than we're changing.
Right.
So the pace is even going to have to get more rapid.
The Quality Alliance we touched on a little bit, but obviously that is the tool for building that clinical integration in the market now. And we'll talk in great detail about that in the third panel. This next one, I think, is the grail for so many health systems, which is understanding population health management, developing those systems, making those investments. Something that both systems had some experience with. What do you see in that niche going forward? What are some of your big goals for making sure this enterprise is able to deliver on that promise?
Well, we said at the outset, what we want to be able to do is prove that we can achieve the triple aim. We'd be the first maybe major system that could come out there and say we truly improved the patient experience, we improved quality and safety, and we were able to do it at the best cost. And with the clinical integration model, and really built around the Quality Alliance, using the support of the tools of technology, of big data and the analytics and the predictive modeling, which we now have, I think we will be able to be successful with a population health management strategy, even as we get bigger, which, again, we want to do.
Sure.
You have to build the building blocks for population health management. It's actually possible to one day flip a switch and go into population management and go broke. Because it's not a system that we can get paid for yet. So what we're having to do is we're having to build the building blocks of population health management, and the Quality Alliance is a major focus of that. I can't overemphasize that, because here's one of the interesting things is that if you look at clinical preference items, we're rapidly standardizing in this big system clinical preference items. So that is just something that you couldn't do if you don't take the time to integrate the physicians first, and then you take the step to standardize clinical preference items. You can't do it the other way around.
Right.
You can't go in and say, hey, today we're going to standardize clinical preference items, all you guys come along with it. It has to be the first and build out.
Right.
We have a lot of physician committees now that are working on how do we get pathways, how do we adopt, how do we standardize, how do we get the clinical preference items in one vector. So this is how you have to do that.
And let me add to that, Jim. I think a lot of our colleagues, as we all struggle with, how do you move from a fee-for-service to a fee-for-value,
right,
which is population health management ultimately. And what we have believed and continue to work around this concept is that our ability to move that, because we still have fee-for-service obviously in our markets, but knowing we've got to move to fee-for-value and we want to move there at this pace, if not ahead of the market, and not fall in the crevice here, we believe the Quality Alliance, in concert as a preferred network working with the health plan, is that bridge that will allow us to do that and to be able to respond not only to the market, but I think also it allow us to help transform.
Well, and I've heard it described that doing the right thing is in many ways putting you out of business. Mm-hmm. That the Quality Alliance, and I've heard others describe it this way, that you really, if you're doing it right, you're taking money from one side of the health system and move it to the other. You're talking about reductions in admissions and readmissions and volume and physician utilization. It sounds like you've really set the organization on the path to just go with the Quality Alliance, and it's the right thing to do. But beyond that, it really is the business of healthcare going forward. That if you're not going to be a clinically efficient enterprise, you're not going to be able to go to the market with those types of products. Right. How far along are you on that path? Because I guess CEOs struggle with how much risk do we put into that.
Well, it was interesting, and again, you're going to hear a whole lot more about this from the ones I consider our experts in our team that talk about this. But when we created the Quality Alliance, and at that time it was a Better Quality Alliance because we hadn't merged, the first population that we put in there to be managed was our own employees, our self-insured plan. So we already had 34,000 of our employees and dependents that went into it, and now, after that's been in effect for a couple of years, we have a year's experience, and we can show that because of the way our clinicians deliver care and using the CarePass, the standard order sets, the protocols, generic prescribe, all of that, we've got significant results. And for the system, from a financial, it saved us $14 million. It was a reduction of $14 million. We had reduced admissions by about 5%, and readmissions, 30-day readmissions, we reduced almost 15%.
Absolutely. The last bullet, and we'll close with that, is continue to see strategic growth. This isn't the end of the story, so to speak, but talk about what other thoughts are there. What are the types of partnerships that you're thinking about that are going to fit in that, or who knows?
And it's in our plan. Yeah. It is for strategic growth because we do that and we have opportunities. I think the key is finding strategic partners. And as Bob mentioned today, through whether you own it, you partner with it, you joint venture with it, we are able to offer full continuous services. But you don't have to own everything to continue to grow. There's a lot of different models out there. I'm amazed at the uniqueness. We're back to some of those arrangements that no one ever thought there would be. But I see that happening. And so as we grow, we may have the opportunity to grow organically, obviously, but we are going to grow through collaboration, through partnerships. One of the things we created was the Texas Care Alliance that you've heard about. And again, there's a lot of ways, and we're having a lot of discussions. People are calling us, but it's got to be strategic, and it's got to be aligned. Mm-hmm. The cultures have to match as well as we go, because your partners are who you are too.
Sure. Well, gentlemen, thank you for your time. It's, again, a fascinating question, and we appreciate your perspective from the CEO's side of what bringing these two great organizations means. And with that, we're going to turn to our second panel, where we're really getting to the nitty-gritty of how to actually do it and put all this together. Just a couple of reminders for those who are watching online. Please do go ahead and get your questions in. We really do look forward to getting as many of those as possible. We've got a few in already, so we really appreciate that. really good questions about the integration of these two health systems. Again, if you're having any technical issues, please go ahead and get those taken care of. Hopefully we can just go ahead with that. Just on a schedule note, we'll have about 45 minutes or so for this next panel, and then after that we'll take a break of about 10 or 15 minutes after that before we go on to our third panel. Well, let's just let our panelists get settled here. All right, so we heard the two CEOs describe the vision, and here's the team that had to actually make it work, or part of the team, I should say. And I want to go ahead and introduce our panel here for the best practices plans for integration. To my far left is Lavone Arthur, who's Chief Integration Officer of Baylor Scott & White Health. Got a little Dr. Irving Pringler, who's Chief Medical Officer and Senior Vice President for Baylor Scott & White Health North Texas, which I guess is, think about it in terms of the legacy Baylor part.
Right.
Rosemary, look, I'm getting my order off, but I'll figure it out here. Where is it? There we go. Dr. Carl Couch, who's president of the Baylor Scott & White Quality Alliance of Baylor Scott & White Health. Rosemary LeQuire, who is Senior Vice President and Chief Nursing Executive for Baylor Scott & White North Texas. Finally I got it right. Glenn Couchman, who is Chief Medical Officer for Baylor Scott & White Health Central Texas. Essentially the legacy Scott & White. Well, again, thank you for, right here. Finally. Okay, so we talked in the first panel with the two CEOs about the direction. The timing, bringing these two great cultures together. With that, you need a plan, how to make it work. And this is a big merger, no question about it. And we broke it down into some steps, and again, these are included in the case study that's part of the program. But Lavone, let me start with you. Talk about this first one, which I guess is not first by coincidence, the common vision among leaders. Talk about how key that was.
It's extremely key, both pre-merger and post-merger. One of the things that we learned and that you heard Joel and Bob talk about was the two of them, as the leaders of the two legacy organizations, discovered that our two organizations had a lot in common. We already shared the same vision. We had the same vision for healthy populations across our organizations. We had the same visions for the relationships and the importance of the clinical enterprise. So that became kind of a natural. The challenging part was then, or what we thought would be the challenging part, would be to bring those together and develop a single common vision that not just the few of us, a dozen or so leaders, but 36,000 employees across the combined organization can get their arms around. What we discovered, as you heard, is that was actually quite simple. We shared the common vision already. We shared a common mission already. All of us have been through those painstaking efforts to develop mission statements and vision statements, and it was much easier for us because from that regard we were already there. How to implement that and get that message out, we'll talk about in further steps, but that became the work of the vision.
Open it up to the panel.
Yeah. I would add that during this exercise when we were working on our vision, we were talking about the values of the organization. Mm-hmm. And really, there are a lot of common values that I think a lot of healthcare organizations have, but the only really new one that we added from the legacy Scott & White perspective that Baylor had called out in their previous value statements was stewardship. Mm-hmm. And servanthood is something that we do is very natural. The excellence, the teamwork, the innovation, those things were already common to our values at Scott & White, but we'd never really called out servanthood, and yet we had been living that and experiencing that and practicing that largely through our health plan, but just kind of the core values of our employed physicians and all of our staff. So it was a easy transition to the new values as we work to develop a new mission and vision.
You know, I think to add to that, for the clinicians, I think it's even easier because they're so focused on patient care.
Right.
And their focus is on excellent patient care. So I think for the clinicians to come together, that is really very easy.
I want to emphasize the values, I think it's just everyone's personal values.
Right.
If you look at the success of whether it's financial, whether it's medical staffs working together, physicians working together, at the end of the day, if there's a disagreement, it comes down to values. And I've been amazed at, because we share those same values, patient-centeredness or how to take care of a patient, looking at evidence-based, going down to this is what we believe. It's so common that we've been able to get through cultural differences, financial differences, and I really do think that's one of the keys to this success.
And let's talk, and you segued nicely into step 2, which is, again, some of these are somewhat overlapping, but Dr. Pryor and Mr. Allison described the cultural fit. And I think unquestionably you had two very similarly aligned organizations, geographically sort of contiguous. But cultural fit takes work, as the slide suggests. It's not just, here's the mission statement. It's not just getting up there and everyone saying, I'm trustworthy, loyal, thrifty, or whatever. It's working it at the unit level. It's every ED department throughput meeting. It's every med staff reorganization where you aren't going to be in every meeting or your representatives. Talk a little bit about how in an organization this big you make this culture live and work and spread day to day.
Yeah, I think, it was clear, as was stated before, that from our board, we were going to be one.
Right.
Those were our marching orders, but you can't order healthcare professionals, hey, just get together and these are our marching orders. It's involvement. It's involvement and representation from both areas to make sure that everyone has a voice. For example, in one of our value analysis teams, one group wanted to use one product, the other wanted to use another product. Evidence showed that they were equal. Obviously, there was a price difference. I know this is unusual to the rest of the folks in the country that doctors disagreed, but the innovative approach was, and I think it was an outstanding idea. I wish I would have thought about it. Is they had a pig lab. Okay, they got the surgeons together, and they worked with the equipment, and they came to a decision. And that was involvement. And then we had a luau after the pig lab.
Well, one of the challenges I think, and you described it well, is you say everything, and I've yet to meet a health system that didn't say they were patient-centered, patient comes first and all that. It's on more plaques and more lobbies than you can imagine. But what it gets down to is often you have very respectful but serious disagreements on what that vision means. One physician can have one way of practicing medicine that he will swear is best for the patient, and his colleague across the hall will also dutifully swear the complete opposite way is better for the patient. How do you smooth those bumps over? Because they're going to happen.
One of my thoughts about that is that historically in medicine, autonomy is highly valued. It's highly valued by practitioners, by physicians.
They're trained into it.
Yes, but it's also, there's individual autonomy, but there's also local autonomy.
Right.
And that's manifested by saying, that's not the way we do it here, even though you do it differently there. And I think that one of the things that helps to bridge the autonomous thinking that most of us sort of grew up with is data. I think that's helpful. And the other is association or interaction. Nothing is better than to put us in the same room and talk and work these things out. And so there's been a lot of driving up and down Interstate 35 where we come together and have some very excellent meetings that help to bring those perspectives together. But the other is when those meetings can show data that indicates an advantage one way or the other, it's easier to adopt the best system, and best care emerges out of that. We're already beginning to see that.
And Rosemary, talk about the nurture. Nursing cultures can be so distinct. Often down to the unit level, culture can be distinct. How did those two systems bridge? Because and I think we talked in the case study about the model is a little different too. What was some of the work that you went in? Because if your nursing staff culture isn't put together right, nothing else matters.
Well, if you look at our employee base, we have 9,700 registered nurses in our employee base, so it is a large group.
Yeah.
And if we're talking about cultural fit and alignment, we don't want drones. We don't want people to do exactly everything we say because we don't want to squelch innovation. So I think we're early in that work, to be quite honest. The chief nursing officers have come together across the system. They have agreed on a professional practice model, which really is the conceptual model of how care should be delivered. That influences job descriptions, it influences expectations of staff, and that really drives us to the same type of care. So it's early in that process to socialize that across 9,700 people. Takes a little while to do that. But we do have agreement, and I think that actually it's really looking very good because we have a retreat next week with all the chief nursing officers, and everybody's going to share their best practices and also share things they're struggling with, so we can help each other, which will drive that.
Step 3, synergies. Obviously, bringing these two organizations together, you expect some. That's part of it. Lavone, talk a little bit about where did you identify some, and how did you come up with a plan to maximize those? Because this can be where there is some pain, there's some overlap, and some redundancies that you have to deal with.
Yeah, absolutely. I think if I had to choose 2 words to define the characteristics that are important in an integration of this size, the first one is flexibility, because you learn a lot along the way. The second is courage, because you have to make some hard decisions along the way. Pre-merger, we did a financial analysis of what the new organization would look like as much as we could at the time with the access to the data that we had. And we made some assumptions around where we could achieve some economies. So we put some targets in place pre-merger that we keep in front of us every day. Now, from day one forward, new opportunities have been identified. And so we've put some structures and some discipline in place to measure those benefits. And again, to keep that in front of us. We're incented by them. We report them to our board. It's very important to them that we stay on top of our financial synergies. And as I said, synergies to me are the benefit of bringing 2 organizations together that would not have been achieved otherwise. So financial is an extremely important component of that. But we're seeing synergies in other qualitative areas, patient safety, quality, access, by best practice sharing. And that's really where our benefit's going to be, because those will result in financial benefits down the road.
One thing that when we talk synergies, we often talk financial.
Right.
And I learned this and have seen it happen just prior to our merger and then as the merger has gone on, but it's synergies and influence, okay? Influence in leadership, influence in medical leadership, political leadership, just really all around, and I think that's a synergy that's also extremely important.
Well, and we didn't talk about it in the first panel, but you would expect some clinical synergies as well, as when you combine these 2 enterprises, you can look back and say, well, Baylor has this transplant program, or this, this clinical trial, or you can go down the list. You can look differently at how those synergies work. I would imagine you found an awful lot of those clinical synergies that made sense when you combine the 2.
And it happened naturally many times, even before we said, hey, transplant, why don't you get together with Central, or orthopedic Central, why don't you get together with Dallas? It was natural, and many of these service lines started independently. We thought the clinical enterprise would be much slower than our integration of our financial enterprises, but our physicians and nurses have worked very closely together from day one.
In fact, that was one of the challenges early on was keeping appraised of all the activities and all the ideas that were going back and forth, and people were getting out in front of us and, hey, we want to do this, and we're ready to go do this, and I want to open a clinic here, and we're going to work with these guys over here, and we were trying to kind of rein them back a little bit to really just to establish really what our needs were and priorities of where we could spend our time and energy. But I totally agree. And I think that the synergies on the clinical side did develop more rapidly than we thought. Getting back to some of the things that what Joel and Bob talked about, there was a lot of trust back and forth. And actually, that was probably facilitated a bit just by the market forces in that the geographies were not so contiguous and overlapping that there wasn't a competitive spirit between the two. So there was opportunities to share both in the education areas, in some of the research areas. So there were a lot of platforms that they could interact on, and all those things built more trust, which just then kind of fed into looking for more opportunities for synergies.
We're seeing great synergies, I think, in some areas, such as our ED Council. We've had a very robust ED Council for many years, and now Scott and White and Baylor leaders come together for that ED Council and sharing best practices. If you look at the two together, we have over 800,000 ED visits, so it's significant per year to the system. And so the ability to standardize policies and practices across all of our EDs is pretty significant for us.
Another area where there's been a lot of synergy is the sharing of ideas back and forth on the patient-centered medical homes. The Legacy Baylor group really had robustly developed that. You have 60, how many?
325 PCMH practices in
so
our employed physician group in the north.
So they were way far advanced in achieving those levels of certification than we were. But boy, there was a free exchange of ideas, and there's a process that's fairly involved to get those certifications. A lot of the services were already in place, but there's been a very open exchange and a welcome sharing of ideas and kind of coming together to accomplish that across the whole system.
And related, but equally important step here is talent management. I mean, we talked about it some in synergies, but you've got a different sort of HR enterprise to look at. You've got some overlap, some new opportunities for people, which sometimes gets lost in the vision. With a bigger company, all of a sudden you may have a leader who's got this one small unit who all of a sudden has this great big one. Talk a little bit about the talent management, because that's that enterprise, 36,000 employees. That's a complex question.
It is, and as Joel and Bob mentioned, they identified the key leaders early on, which I really can't emphasize enough how important that is, pre-merger, because you want to start the merger the first day with knowing who the leaders are in the areas and being able to implement their plans. That's the way that you achieve the synergies and all the other benefits that you get. But you do have to make some hard decisions in doing that, and it's not just at that top leadership level. Now with our leaders working down in the organization, you really have to put some focus behind identifying the key talent throughout the organization. And sometimes that's hard if a leader is a legacy Scott and White leader. They know their team, and they have to spend time getting to know the Legacy Baylor team, or the Legacy Baylor team has to spend time getting to know the Legacy Scott and White team, because now that leader is responsible for both and all of them. So identifying that key talent, it's a time of change. Change management is critical with this in this process in identifying and retaining your talent. So being creative about some of your retention strategies is key, and just knowing that up front that you're going to have to implement and put some of those things into place.
Other thoughts on your teams, how the talent management went?
One of the interesting things in healthcare today, physicians and hospital administration have often been very separate in our cultures for years, and both organizations.
I've heard that. It's come up once or twice.
Most people realize that, and both organizations have a long history of physician leadership development and trying to grow physician leadership in their administrative and leadership and management characteristics, as well as their clinical characteristics. And so there's been a real effort there on both sides, both of our two institutions, to develop that, and that has continued and is now one of our areas of synergy.
We've even graduated 2 classes of, it's called the Scott and White Executive Program, SWEEP. I'm left out an E, but we have SMU courses. Carl founded one, Rosemary founded the other, and we've already started our development for nurses as well as for physicians.
Our SMU program, we have a cohort of about 30 high potential nursing leaders every 18 months that go through that program. This next program kicks off in 2 weeks, and we have leaders attending that from now the Legacy Scott and White and the Legacy Baylor together.
And on the physician side of that, we have the Scott and White Executive Education Program, which we do in collaboration with a lot of the faculty from the University of Texas Business College, where we've split the class. So we have 15 physicians, leaders, up-and-coming leaders from the Legacy Baylor and 15 from the Legacy Scott and White, and we go through a whole business program with them over a year's period of time.
How do you manage, a key part of this talent management, you talked about getting ahead very early, in many ways, making sure you've got leadership in place in the very early stages of merger discussions. But inevitably, we live in the real world. These are complex organizations. You're going to have people who, through the process, just figure out they just don't want to be part of what we're building here. Jim Collins, I'm sure we've all read, says basically get them off the bus. But how do you manage that in a way that's, that moves the organization forward, that's not too disruptive, because it's going to happen?
I think it's communication. Again, as I told you that we had marching orders from the beginning, I think the board and leadership have been very clear about what our objectives, what our goals are. We want to support everybody. We want to make everyone successful, but at the end of the day, after you've communicated well and been clear about your goals, I think then maybe this isn't the right place to be working.
And it does go back to the issue that was talked about earlier with trust, and it's building the trust in the rest of the organization and the rest of your senior leadership team, that if and when someone makes that decision, they know they'll be treated fairly, that they'll be wished the best and will be successful somewhere else. And that's whether it's the organization making the decision or it's the individual making the decision. It's all about treating someone fairly based on that and the trust that's going to happen.
And you segued into this as well, communication. And I guess that really boils down to making sure, and Joel talked about doing site visits and that type of thing. But you can't oversimplify this. This is very, 36,000 employees across a wide area, all working very difficult jobs at odd hours. How do you make sure that all of this mission, vision, and values is not just communicated once or twice, but reinforced?
We've put we have a wonderful communications team, so I'll start with that. And we have put detailed communication plans in place to assure that happens. We've developed, as was mentioned earlier, we have websites that are accessible for all employees to make sure that they're getting the same information. We've developed integration newsletters that go out electronically to all employees, as well as hard copies in some cases. So any type of media, we're accessing our social media, any type of communication vehicle we have. We try to communicate regularly with leaders and give them toolkits that they then take and can communicate down, cascading throughout their organization. So communication at this point in the integration, from day one to now to the next 10 years, is probably the most important factor in an organization this size, because we're not just 36,000 employees. We are geographically spread out. Texas obviously is a large state, and just our service area where our employees are larger than many of the states in the U.S.
What are the types of communication you're talking about? Because I think often what happens is maybe health systems are guilty. What they're communicating isn't of real value. It's a lot of happy talk, coming from on top. Doesn't strike me that that's the tone here, but you have to be transparent. That you are sharing a lot of information about this is where we are. These are the the standards that, it's not just the volume, but the quality of what you're presenting.
One of the vehicles that's been developed, I think, that was very creative is an integration newsletter for leaders. And the way that it is divided is it has information, and there's a key to it that says if you just have 5 minutes to look at this or 2 minutes to look at this, there's a key that says this is for your information. There's a key that says hot button, this is something you need to know, and then there's a key that says you need to know this and you need to communicate it. So as a supervisor or a manager pulls up that newsletter, they can take a quick look and say, oh, these are the 2 things that I need to communicate with my staff. So it may be changes in policies, a lot of those coming out, changes in processes that affect them directly. So we recognize the fact that you can almost over communicate. We get a lot of email fatigue in the organization today. So how do you tag those things that leaders especially and employees need to really pay attention to? So we're trying to do that some on the front end.
But you know, one of our values also is servanthood. And so supporting our staff and being honest with our staff and authentic with our staff is crucial. And I think that that's what's gotten us as far as we have gotten in such a short period of time.
I did get a question that it touches back a little bit on the leadership development piece, but how are leaders identified? And the question is, do both organizations come to the table with a list and sort of discuss, or was it more about a broader collaboration where you're talking about some agreed upon goals? I mean, in practical terms, how do you start to put that organization together?
So I can tell you how we have done it on the provider side. Legacy Scott and White has had department chairmen, chief medical officers, chief nursing officers have nominated people that they are responsible for. Those go to a single individual who then is meeting with a group of the program director for that, some of the executive leadership group, and we kind of vet that whole group and we decide who would be most appropriate for that kind of education. I'm not actually sure how we got the list of names that were sent forward. I suspect that you have a lot to do with that.
But ours is a little less complex. Basically, we asked the presidents of the hospitals, we asked the leaders of the Quality Alliance, as well as Health Texas organization, and they nominate physicians. Rosemary does the same for nurses. So we include administration as well as our chief medical officers and all. We have different levels of leadership. We may have one-day boot camps for someone who's an officer that needs to learn governance of a medical staff. We have others that are going to be, that we think may be a chief medical officer one day, and so we offer the SMU or the SWEET program for even more advanced. We also do succession planning, which we're in the process of now, to say, are there young leaders that, could be next in line for a chief medical officer or a leadership position that we need to develop, and what development do they need?
In our Quality Alliance, everyone here and on the audience probably agrees that communication with broad numbers of physicians is often difficult. There are no single methods that seem to be foolproof. And so one of the things that we've focused on inside the Quality Alliance, we'll talk about it in a bit, is kind of a distributed, I often refer to it as the square root of N. Yeah. If you want to influence N people, there's probably a subset of folks you need in order to accomplish that. Because everybody has a sphere of influence. I personally think it's kind of 10 to 1. Right. And so we work hard on a large number of physicians who are charged with carrying message to their sphere of influence. And eventually you can get out to a large number.
Not to overlook some of the more practical concerns. I mean, you need a project infrastructure, and really discussing infrastructure, we haven't touched on that. But that's a big deal, and we haven't even mentioned, and I did get a couple of questions. We're talking 2 different electronic medical records. A lot of health systems just look at that integration and just scares them to death. Talk a little bit about making sure that you had all the other I guess, more mechanical pieces that we're going to run, that your quality teams are coming together and that type of thing?
Yeah, from a project infrastructure perspective, we determined early on pre-merger that we believed that we had the talent to drive this internally, that we weren't going to inundate our folks with a large consulting group to help us through that. So we identified some talent that we had within the organization and redeployed them and created our own integration management office, basically. And this was a staff that have project management expertise, lean expertise. They're used to working in the clinical as well as the business areas and process improvement. And we basically assigned them to our different integration teams. Again, primarily the business teams, finance and marketing and those types of areas that were coming together early on. Although they've done some work with some of our clinical areas as well. In addition to that, we put together a structure, I think as Dr. Pryor had mentioned earlier, we put together an operations council which really acted as our integration leadership team. And the leaders were responsible for coming in and reporting their integration plans, presenting, getting approved, and then implementation steps for their integration plan beginning on day one. We provided to them basic technical stuff, templates, and again, project management support to help do that. Because one thing to keep in mind is, while our leaders were responsible for integration efforts, they were also continuing their regular day jobs. You know, we have to keep both organizations running, and it was very, very important to us to not take our eyes off the ball of running legacy Baylor and legacy Scott and White day-to-day operations. So putting infrastructure in place to provide that support economically was an emphasis for us. We did use some outside consulting in pockets where we identified we had a need for that. And so that was approved and that moved forward. But overall, we've done most of it internally. On the quality side, again, that was one of the areas that came in and presented. Here's the quality initiatives for the next 30 days, 90 days, 100 days, 6 months, a year. So it was really, again, it's putting that discipline in place to have the plans presented, reported, and then monitored.
Talk a little bit, and again, I know we don't have the IT leadership up there, but that's a big piece of it, that you needed to particularly, to get to the broad vision of what you're trying to achieve, think about in terms of how you move data around. And we'll talk in the next panel about how it works in the Quality Alliance a little bit as well. But, was it the IT integration built into this project?
So I would just say this is still a work in progress for sure.
Sure.
We had another little project going on in Legacy Scott and White while this integration was going on. Is we converted everything to Epic across all of our hospitals and across our entire system. And we did that in a rolling fashion, but it was truly a big bang in that we did the hospital piece, the outpatient piece, all the lab, the ancillary services, and that began in June. In Round Rock, and the integration all officially became ongoing in the fall, and in February we did the largest hospital in the system, Memorial Hospital in Temple. So that's the infrastructure. The electronic infrastructure is still being rolled out as we speak. We are certainly looking at ways that we can learn from that, apply that to all the different challenges we have across the North. We're adding new databases there and analytic pieces to the BQA to try to collect as much of this data as we can. But boy, talk about a work in progress.
Sure.
This is going to be rolling out for years.
And at the same time, we've just pretty much finished the electronic health record implementation in the North. And so the question becomes, how fast do you need to get to the same platform? Do you need to get to the same platform? What's the method to get to the same platform? Can you use a health information exchange to help you get there in the meantime? So it is a work in progress.
But one of the challenges in aligning all of our practitioners in this is Central Texas physicians, roughly 1,100 physicians have been employed and are all part of the same electronic health record that Glenn just alluded to. In the North, we have roughly 4,500 physicians on our combined medical staffs of whom about 2,600 are members of the Quality Alliance, but 2,000 of them are independent, and they have 70 different electronic health records. So suddenly you have this complex environment, and which also, as we grow and as we begin to move into other markets, as Joel and Bob alluded to, even in Central Texas, some of their new hospital communities are beginning to encounter independent physicians who also have different electronic health records. So to the one solution that does seem to make some sense is we have just purchased a health information exchange tool that we hope can begin to link these disparate systems together, because it's highly unlikely that they'll all be on the same system for a very, very long period of time.
Sure. Dr. Pringler?
One thing, in addition to the electronics and exchanging information, which is extremely important, I think one of the biggest culture building exercises that we'll do is, right now we're looking at both electronic health records to say which offers something that the other doesn't. We're looking at order sets. We've got combined physician and nurses, multidisciplinary approach to say, how do we come up with one set of order sets for all these that we both develop individually? And I think at the end of the day, you have to be prepared for the electronic health record. So I think when we make that decision of when we go on one electronic health record, I think all the infrastructure as far as the order sets and pathways will already be in place, and that culture will have been built.
Let's talk, and Lavone, this was in the case study as well, and we've talked about infrastructure, but organizational design, that's, I guess in a broader sense, some intelligence around how do you plan for growth?
Right.
Talk a little bit about the design you put in place.
Yeah, so as alluded to earlier, we, in our pre-merger activities, the organizational structure was identified, what it was going to look like on day one, plans being developed for what it might look like in the first 100 days, and then even now a year out. This is also kind of a work in progress. What we are learning is that we are tweaking this almost every day. As we learn about the system, as we mature as a healthcare system, we discover that our organizational design, does it look like today, a year ago what we put in place, is that going to satisfy, or is that going to meet the needs that we have today and in the next 6 months or the next year? As we look at growth and new opportunities, then we really have to look at organizational design again, organizational structure, how reporting relationships evolve. And when I talk about organizational design, there's a couple of components to that. One is governance, which obviously was identified early on, governance at the board level, as well as at the leadership level. But from an organizational design perspective, the other component to that is just what structures do you put in place to allow efficient decision-making processes? Because part of our cultural design, part of our organizational infrastructure, a lot of that revolves around decision-making processes. So what we have found is that we had some differences in our decision-making processes, and when we come together, we have a whole new set of decision-making processes. So you need to design around those to be efficient. You could easily bog down an organization this size if you overcomplicate and overstructure appropriate decision-making processes. So that's been a big focus of our organizational design.
Well, and ultimately, when you say decision-making processes, you're talking about autonomy to make decisions. That
Right.
You want to empower that innovation, that unit leader to innovate and not feel like that they're just going to have to follow a script that's written
Right.
4 levels up. Let's circle back around, and we have a few more minutes for this panel, and I want to encourage, again, those who are listening online. We've got some good questions in, and I'll get some in, but if you have some more, please do. We talked about the sort of leadership direction, but now we're talking about leadership engagement. They can't just go away. The boards, the leadership of the health system, how do you use that leadership in the best way? Because let's face it, they don't. They've got other things to do, driving the organization, thinking strategically about what to do next. dealing with the regulatory and political structures, all those different types of things that a lot of your leaders need to do. Mm-hmm. How do you keep that engagement and, I guess, momentum going forward?
I think from a leadership engagement perspective, again, it's all about communication,
right?
The effective communication, and it's about providing leaders the tools they need to be able to effectively lead their new organization. In many cases, we have new leaders that are stepping up, and I'm talking about leaders all the way through the organization, not just at the senior executive level, but being able to identify those leaders and then provide them the tools that they need to actually effectively lead. And in some cases, leaders are formal leaders, and in many cases, leaders are informal leaders, especially in the physician community and in the clinical community. But how do you identify them and then provide them the tools they need to keep them engaged in the goals of the organization? And as the organization continues to grow, that becomes much more important and much more challenging, frankly.
So we've approached it across a lot of the physician areas with really, again, the communication piece and just looking at multiple opportunities to get in front of the physician groups, the nursing groups, small town halls. Not that Joel and Bob have been doing big town hall meetings, but where you get into some of the more difficult questions, and you alluded to, well, you talk happy and stuff at the big meetings, where you get into the real nuts and bolts are in these small venues. And when I have a variety of different opportunities to meet with department chairmen, board members, division levels, I have those on a weekly basis. And so a lot of my time is spent just going out, communicating, making sure they understand what the system goals are, how those translate into what our expectations are for their particular area of responsibility, and how that all cascades down to the ultimate success of the organization.
How do you deal with, and I don't know if you've thought of it in these terms, but integration fatigue? People we're talking clinicians, nurses, physicians, who just want to take care of patients. Enough already, no more meetings. But dealing with that's got to be a temperature you need to take every now and then, that you're not overwhelming them with meetings and communiques or whatever it may be.
That happens in healthcare, whether it's integration or quality. Here's something else that we feel we have to do on the front lines. But at the same time, I think you communicate, and communication is a two-way process. So we've got to hear as well as speak. And as Glenn said, it's very important for the senior leadership to go down and speak one-on-one, to listen to that, to make sure that we're not overdoing it. I think these engagement surveys, they have a comment section. Okay?
Right.
Some of those comments can be very interesting. And so, I think we have several ways to look at it, but that will tell us how we communicate. The comment section will tell us if we communicate too much, and then I think the one-on-ones are probably the most important.
So, but I think so. You have to really time what you're doing.
Right.
So, if there are specific integration strategies, or let's say implementation of new products, you can't do all of that at once. You have to time it. But I think in terms of leadership engagement, I think many of the staff and the frontline managers have been very excited about the merger because it gives them greater opportunity for growth.
Yeah, I'm experiencing that too. I see people are fatigued on all the emails, but there's still a level of excitement, and there's still just enough dynamic tension about really what's this, what is going to be changing, because we are changing benefits and we are rolling out a lot of new things. So there's still a lot of desire to hear more, and they want an opportunity to ask questions and stuff. So at this point, I'm seeing more engagement instead of less engagement, really.
I heard there's an ICD-10 diagnosis of integrative fatigue syndrome.
Yeah. Well, I think the government decided we won't do those until 2017. Well, thank you, everyone. This has been a terrific panel. At this point, we want to go ahead and take a break. The slide's not quite accurate. We want to try to get back together in about 20 minutes. So at about 10 minutes till the hour, we'll come back together. And in our last panel, we really will get into the vision for the Quality Alliance, which is, again, the clinical integration tool that brings us all together. So, again, thank you for your participation, and we'll see you in about 20 minutes. All right. Well, welcome back to Dallas, everyone. It's balmy, probably 105 degrees outside, but we're in our lovely auditorium, and I want to thank again Baylor for their hosting of this event. We want to continue with our program and our final panel. We've introduced first the strategic view of this merger and clinical integration plan, then sort of the organizational view of how you put these two organizations together, and now we're able to get down to the real nitty-gritty about the clinical enterprise. And we're joined, I want to introduce our panel again. We're joined by Dr. Couchman, Rosemary LaQuire, Dr. Pringler, and Dr. Couch. Really talking about a physician-led, collaborative, and accountable clinical integration plan. Well, when you boil that down, what are we talking about? We're talking about the Baylor Quality Alliance, aka the Baylor Scott & White Quality Alliance, and now you just got rid of all the superfluous ones, and now it's the Quality Alliance. So all the same entity. Dr. Couch, this is really the organization you're charged with leading. Talk about what you've been able to accomplish in the past couple of years.
Well, as we formed the Quality Alliance, we realized that the purpose of the Quality Alliance is really around clinical integration, but it's also, as Joel Allison and Bob Pryor have just talked earlier, it's really about achieving the triple aim. And so from the beginning, it was creating a broad understanding of what clinical integration actually is, and how does that differ from where we've been. So one of the things that we've had to do is to not only recruit members of the Quality Alliance, which is mostly physicians and hospitals, but then others as well. But secondly, to build an understanding of what population health really is and develop some of the infrastructure and tools to begin to accomplish that. You see some of those pictured on this slide. We at this present time have about 3,700 physicians that have chosen to be part of this, as well as all of the entities, facilities and entities that are part of the Baylor Scott & White health system as well. Each of the different structures that you see there are real, and they exist, and there's been a great deal of effort in trying to put those together. There's a capital investment in creating an accountable care organization as well. You read estimates that for a system our size, $10 to $20 million may need to be invested in creating this infrastructure to take care of population health, and actually we'll be in that range as we have accomplished about 3 years of operation today. So one of the things, you might advance the slide, Jim, you can see that our total physician organization of the North Group is about 2,600 physicians. Then we add the physicians from Central Texas, we'll be at about 3,700, and that actually will be formally completed next week. If you put those numbers together, 1,700 of those doctors are employed by our healthcare system. Roughly 650 in the north and over 1,000 in the central region. But 2,000 are independent doctors. And independent doctors value their independence. They tend to be quite autonomous. They have multiple EHRs like we've talked about. And in Central Texas, as I think we mentioned on the previous section, they're encountering independent doctors as well in the various markets outside of Temple in particular. And so how do you relate to those people? One of the things we do is we recognize that all doctors don't want to be employed. In fact, we need independent doctors of various specialties. And so we emphasize that this is not an effort to make you be employed. It's an effort to integrate with you. And in fact, more than integrate, to engage with you around the objectives of the Quality Alliance.
Describe your independent universe. I mean, you mentioned in numbers there's 2,000 of them. Give us are you talking large multi-specialty groups, very small practices? What's the universe like?
The universe is all of the above.
Sure.
Dallas-Fort Worth has large citywide single specialty groups. It has a few multi-specialty groups, but it has a lot of small groups. 5 to 10 and considerable number of solo practitioners still around, and that all of whom have chosen to be part of this. One of the things that's interesting, you would think that the employed group is automatically bought into the idea of accountable care. But accountable care involves not only a commitment to quality, which we've all been committed to for many, many years and have a long journey of that, but it has to do with a commitment to cost effectiveness and clinically integrated. And those are two very different concepts. And yet every doctor, including the independent doctors and the employed doctors, had to sign an individual agreement saying, I want to be held accountable for all of those three things.
One more quick question about the independent physicians. What's the breakdown specialist versus primary care?
Roughly, we have 325 employed primary care doctors in the north, about 300 in Central Texas, and about 70 independent primary care doctors. So roughly 650, 700 out of the 3,700 are primary care.
The rest specialists? Absolutely. I guess the question is because you think of ACO structures as being really a primary care vehicle. It brings in, patient-centered medical home practice. When you're talking about the troops to be able to deliver this care, it's interesting to me the different mix that you have. That you do have so many independent specialists involved that you've been able to get that buy-in across the board.
I think doctors independent doctors have joined the Quality Alliance for various reasons. Some absolutely get it. They know healthcare is changing. They want to be part of that transformation. I think there are others that just joined to cover their bets and to just in case this turns out to be something. But at the same time, very quickly, they and all of our doctors realize this is around changing. It's around transforming how we deliver care to accomplish these objectives.
What's your goal in terms of physician employment? You have 3,700. Are you looking to? Do you have a strategy for how big you want this physician enterprise to be?
We've done network adequacy studies as we go along, and honestly, we probably have almost enough adequacy to serve at least 500,000 patients in value-based contracts. So we may need to be a bit bigger than this, but at the same time, we can serve the patients that are on our radar right now.
Sure. And again, one more question about the independent physicians. I think you're talking about the independent physicians mostly in the North Texas market. I mean, this is a group this is a market that's historically been very entrepreneurial anyway. I mean, you mentioned that some of them are made for very good reasons, be hedging their bets. What is it about this Quality Alliance that's sort of scratching that itch where they feel like they're getting that new business model, that they're able to participate in one of those value-based models that we've all heard so much about? But I mean, let's face it, that value-based model brings with it some big changes in physician reimbursement.
One of the things that we've seen so far, we've not actually seen changes in physician reimbursement, although most of our leaders feel like that's coming eventually. If the cost of health care is going to go down, there will be an impact there both for hospitals and for physicians. But most of our contracts have been around what are called shared savings models, and the model includes narrow or preferred network.
Sure.
And so employers and payers are seeking us as a preferred network. Therefore, implication is if you're not part of the network, you'll be out of network from the patient standpoint, and that's been an incentive for people to participate.
I mean, this map, it's a little detailed to read, but I think you get the picture covering the North Texas market.
Yeah, the Quality Alliance, this is on our public website. You can click on any of those blue dots and they'll explode and you can see the North Texas physicians that are part of the Quality Alliance.
But the idea here is you really are getting that market saturation where, from a patient's perspective, if they want to participate, they don't feel like they need to travel in all the way to across town.
Right, and we have worked hard on adequacy, not only geographically, but in terms of specialty coverage. And there are standards that most of the payers have used over the years to determine that adequacy. We meet those standards. One of the things about the Quality Alliance that I think is when you start thinking about accountable care and population health is population health is no longer just about hospitals. It's about, and not just about doctors. It's about the whole continuum of care. And historically, these have been areas where we've had relationships, but we've never tightened those relationships into the idea of mutual accountability. So take, for example, post-acute care. Historically, the transition from hospital to nursing home has been kind of a very finite, you're done with the hospital, you're now in the nursing home, and the two don't communicate anymore. Right. And the end result is inappropriate care, unnecessary readmissions, dropping the ball in terms of the patient. And so we've been very careful to select. In fact, Rosemary, you might want to comment on how we selected the various skilled nursing facilities and home health to participate with us.
We looked across the Dallas-Fort Worth Metroplex at skilled nursing facilities, and there are a lot to choose from. We looked at their quality metrics as reported through CMS, through the CMS website. We scored skilled nursing facilities, and those that scored at a certain ranking or higher were those that we approached. You know, we had several skilled nursing facilities that we've been doing some pilot work with, and we've had educators in their building and a case manager, care coordinator that's followed patients into those skilled nursing facilities. And when we have that type of relationship with the facilities, we see that their quality metrics improve and their readmission rates plummet. So we have really been very careful about who we select to work with based on quality metrics. So that's how these 26 were chosen.
Do you, if you created the linkages, because you mentioned it, often the challenge with skilled nursing and home health, other parts of the continuum, is that continuum of information. They don't know that the medication has changed. You go down the list of causes for readmissions and admissions. Do you have, are you able to create those linkages so it's not just sort of a working relationship, but that the data is flowing back and forth, communication is flowing back and forth?
We have through a case management type model. I think we're still building that in terms of all 26 facilities. We don't have that in place yet, but it is a work in progress. But if you look at where we are now compared to 2 years ago, I think we've seen real progress.
And we will link them through our health information exchange tool. Their information system will be able to have some communication with us directly. We also have a Baylor Healthcare System. Legacy Baylor is mostly in adult care on the institutional side. Central Texas has had a children's hospital for many years as part of the Scott and White family. So we have formed relationships with our local children's hospitals because people buy their insurance for families, not just for adults.
Sure.
And so it's important that as we think of populations that they be included.
Absolutely, yeah. I mean, that's pretty common across the country as you see those partnerships with, it just happened in Nashville actually, the ACO and the Children's Hospital in Nashville, they create that linkage as well. This, impossible to read, but you get the idea. Here's the order chart.
Yeah. I often emphasize, because I think this is terribly important for physicians. Although the Quality Alliance is owned by Baylor Scott and White Health, it is governed by a largely physician board. And in fact, our board chair is a practicing physician. 17 or 18 of the members of that board are practicing physicians. One is a patient, and the reality is this is very physician driven, and that's important for physician buy-in. It's divided into five main committees that you can see, and on the left-hand side is our kind of our heart and soul is our Best Care Clinical Integration Committee, because that's where that committee is charged with integrating care. It's divided into 25 active specialty subcommittees. Many of those subcommittees are meeting with their corresponding service line in our hospitals, trying to integrate for example, a surgery service line and a surgery subcommittee in the Quality Alliance around both inpatient and outpatient continuum of care, inpatient and outpatient protocols, supporting the work that's going on in the hospital with cost reduction and standardization of care, order sets. And so we're trying to it's a huge area of synergy, and we're I think making good progress. You might comment, Rosemary, on the synergy with emergency medicine or OB-GYN.
Well, again, if you look at the Best Care Committee, we do have leaders from certain specialties such as OB, so they've looked at order sets and standardization of products across the system. Emergency services I mentioned earlier, so there's great work going on really across the entire system now, not just Baylor Legacy System. If you look at the Best Care Committee, there are 3 nurses on that committee also. So they are very involved in looking at what are the order sets that impact particularly the inpatient world, not as much perhaps in the physician's office, but more the inpatient world. So one of the chief nursing officers is also on that.
And we're trying to integrate with the work of the Chief Medical Officer Council in the north and will in the central area as well, because that's where most of the hospital-related work goes on.
Right.
And you might have some thoughts.
Sure. And for example, tonight we'll be meeting with the Hospitalist Council, and that's at one time there was a Hospitalist Council for hospitals, and one, when BQA just started, those are merged, and that drives a lot of our quality efforts as well as our utilization efforts. And our chief medical officers and chief nursing officers are very active in really operationalizing a lot of the quality efforts and the utilization efforts that we have.
There's been a lot of synergy there, and I think there'll be some economies that come out of that as well.
Let's talk about, and I want to focus a little bit on the Best Care Committee. Not that one's more important than the other, but it seems like that's the committee that really is deciding or contributing to the heart of what an ACO is all about, which is finding best practices, eliminating variations in care, coming up with a system that allows you to deliver on that value promise. But again, that gets back to clinicians can have very heartfelt, well-meaning, opposing views of what a best practice can be. You might have one guy down in Temple who's been doing things a certain way because that's the way his physician told him in residency to do it, and evidence says to do this, and others may have a different style. Is this the committee that's really sort of working through those, that you can come together and say, well, this is what the evidence shows, but beyond that, is it absolutely critical that everything is exactly uniform? Do you have any feel for allowing some, I guess, appropriate variation or different style of doing things?
I think each of us have had experience in standardization.
Right.
Evidence-based standardization is a mandate today. So when something is evidence-based, we generally want to standardize how we take care of that. At the same time, no protocol perfectly fits every patient, so there has to be clinician judgment retained. But generally speaking, it fits most patients.
Right.
And so you wind up with the absolutely best of both worlds, but at the same time you emphasize to physicians that just because you have a protocol or a standardized order set doesn't mean you turn off your brain. Same with the nurses. Mm-hmm. I mean, judgment has to enter into this. So, but one of the things on the next slide, Jim, is that we have in the Quality Alliance developed about 90 protocols, a few more since that slide was printed, that are in all the different disciplines. And what we asked the doctors in these subcommittees to do, these have been more ambulatory, right, because the hospital, Glenn and Irving and Rosemary have worked hard on developing inpatient protocols, which are mostly order sets or associated with order sets. But the charge to these committees is see if you can identify within your specialty at least one this year quality initiative that is nationally recognized and well supported by evidence, and a cost-effective initiative is where you identify at least one place where costs can be reduced, either inpatient or outpatient, because we're interested in both. So any comments?
Well, just to take off on that, the Choosing Wisely guidelines were something that we had been pursuing outside of this guideline development here. But it fits right in with it, and the departments were focused, especially areas we're looking at those areas, and so it lends itself well to the creation now of guidelines that then have to be hashed out and in the committee work. But it's really been a very, we've not had any fist fights or hospitalizations as a result of those discussions, but it's been some robust interactions that have been good.
And I can't emphasize enough what Carl said is, you know, it's the 90-10 rule, 80-20 rule, whatever. But, you know, we always respect a physician's judgment. A protocol or a care path can't dictate 100%, okay? And, you know, again, personal belief, there is some value-added variation sometimes. That's not, you know, mostly everything falls in the 80-20 rule. But you still have to you have to respect that judgment and what happened at that time, at that moment in time, in the middle of the night, or you know, whenever that was.
And you know, you have this list here, but I think you think about everything that's behind each one of those. I mean, even something. I mean, I'll pick primary care depression, something we've done a program on ourselves. There's so many questions at that. It's who does the screening? When do you have the referral to the psychiatrist? You know, what conditions does the primary care physician care for? What are the screening tools you put in? You can go on and on. It's not just sort of agreeing in broad terms about the care protocols. It's who does the work. Who do you have to hire or not to be able to do it?
There's an interesting thing. If you go to the next slide, go one more. Our low back pain protocol is an interesting example of how clinical integration probably should work.
Right.
We all know, and most people know, that unnecessary imaging is done pretty widely in the United States for patients with uncomplicated low back pain. And so there's been a huge national push on that. And we've reduced our high-end imaging, MRI imaging, substantially through a protocol. But the protocol was developed with primary care, with orthopedists, with neurosurgeons, with physical medicine, and with physical therapy, all involved in the development of the protocol. And the reason for that is it's important is if we're going to measure how that resource imaging is used, or whether or not adherence to that protocol is occurring, I want it to be the same for a primary care doctor, for an orthopedist, because either of them may be the point of entry for the patient who presents with that condition. And so it's if we're going to be clinically integrated, it ought to be a harmonious experience wherever the patient chose to enter the system.
Well, isn't part of that creating the, I guess a tiered or step protocol that everyone follows, so you don't just have the first-time patient coming in with maybe excruciating, you call it uncomplicated back pain. You don't just march them off to the MRI to figure out what's going on.
Right. Exactly. And I think the other thing about protocol-driven or evidence-based healthcare is that if you think about it, it's defining what you want to work on. It's seeking an evidence-based approach to it. It's standardizing around that approach. Then can it be measured?
Right.
Because if you can't measure it, you can't improve it or manage it. Then is that measurement becoming part of a data feedback to those that are doing the work so that variation can be explained and improvement occur? It's a loop. It's a feedback loop, and it's true with every one of these protocols, both inpatient and outpatient. We've been doing it for years on the inpatient side, core measures and all of the things that hospitals, we've worked on it in the hospital side for years. We're pretty familiar with that loop, but it hasn't existed much in the ambulatory world.
And I think we've done a better job even in the last year in terms of putting the inpatient staff together with the physician practice staff to drive these, because at one time we had two different groups. So for OB, we had an inpatient group working on it, and then we had BQA, Baylor Quality Alliance at that time, working on similar issues that could be redundant or not agree upon the same processes. So now they work together.
Well, in low back pain, just to stick on that for a minute, this is a good example where you're really applying the latest evidence to treatment, I would imagine, because the evidence is pretty resounding lately that patient-reported outcomes, surgery versus doing nothing, are almost negligible in some cases. Is this where you can really start to look at the evidence and come up with a protocol that not just saves money, but again takes into account what may work, what may not just putting the patient through all this stuff?
Yeah, I think as physicians and nurses sit in the data analysis part of healthcare delivery, one of the most interesting things is to begin to look at variation analysis. Most people don't like to be on an extreme one way or the other. Doctors, I think, particularly don't like to be outliers. But at the same time, knowing what my own practice pattern is not known by most people in medicine today.
Right.
And so just to see that data sparks good conversations, and I think it tends to drive towards improvement.
Another area identified, generic prescribing.
Yes, generics is widely sought as a population health low-hanging fruit opportunity. Just the almost 4% increase in generic prescribing that we've had for our own employee base population probably contributed between $1.5 and $2 million savings just with 4% improvement. And we've set even higher goals for the year to come. If you move along, one of the things that I think is probably being done by most clinically integrated organizations or accountable care organizations, we think that there are three key parts. On the left is care coordinators. The middle is patient-centered medical home, and on the third bullet is actionable data. One of the things we've realized in population health is that the encounter with the professional, particularly physicians or hospitals, is an event, but it's a brief event. And particularly in chronic disease management, it's probably what happens after that that's equally or perhaps even more important for the patient. I call it the off-radar management of patients. And because when they're in front of me as a clinician, they're on my radar, but 15 minutes later they've left and they're off my radar, and somebody else is on my radar. And that's where these registered nurse health coordinators or health coaches come in. These are people that reach out professionally, proactively to the sickest of our patients. 5% of all patients drive half the cost in the United States. So part of what we work on with our data systems is identifying the sickest of those who need those additional services, reach out to them for both improving their quality, improving their integration from practitioner to practitioner, and improving, obviously, their cost. Many of the patients that they serve have 4 or 5 diseases. They have 4 or 5 doctors. They've been in the hospital in the emergency room multiple times this year. And so, but they have nobody in charge. And so we encourage them to find a medical home, second section. That is somebody who will help to coordinate and be responsible for that. Glenn alluded to the PCMH work that's gone on in the north and is now going on in the central region, and our independent primary care doctors are seeking certification as well, because there's strong evidence that being in a medical home will give you a better patient outcome, it'll give you a more integrated experience, and it also lowers the cost of care by having somebody who will take responsibility in our very disparate environment that we live. And so medical homes have been huge. And then the third part is data. We'll talk about some of our data systems in a minute, but simply that's the feedback part of this, that if you can measure it, then you can analyze where you're not where you need to improve and improve.
Well, let's talk more about the RN health coaches, because this fits into I guess the key that a lot of health systems we work with approach it differently. Geisinger is a case management model. Right down the road in Houston, it's a ambulatory health coach sort of case manager model that are embedded in the primary care clinics. Talk about what these RN health coaches do, and maybe a little bit about who they are, what's their level of expertise.
Yeah, I'll start off with that, and then Dr. Couch can add to it. So we have an individual now that oversees care coordination for the system.
Right.
So that's inpatient and outpatient. And before it was segregated. And so I think that that has made a big difference in terms of the continuum of care and that handoff as patients move through the system. These are very well educated, seasoned case managers that are in these roles. They do use that predictive analytics. So we have a tool called 360 Fresh. It's now recently been purchased by another company. The name has changed. But it identifies patients at highest risk for complications, highest risk for readmissions. So it could say to me, Mr. Jones is at 80% chance of readmission, and Ms. Smith is at 20%. Well, I know exactly who I need to focus on first. And so the health coaches have the ability to look at that tool to understand where the opportunities are and connect with those patients and with their families specifically. And then they have an electronic system now to be able to document everything that they're doing. So we could pick up on that and look at what their interventions have been.
How are they stratified again? Are these inpatient patients who are identified at risk? Or are these folks that are part of your health plans? How do you start to segment them?
It is natural language processing that pulls from the electronic health record and re-stratifies patients. So it now is for inpatient and outpatients both.
Sure.
On the ambulatory side, they do focus on those for whom we're contracted, because these are expensive staff members. They're highly skilled, and so we're only funded by population-based reimbursements to take care of populations that are in value-based contracts. Populations for whom we've routinely cared for dozens of years, if we're only paid simply fee for service, it doesn't support this activity.
Right.
Because there's no fee you can charge for this activity, and yet this activity is highly important in having better outcomes and reducing cost. So part of what these people do, they serve our 4 existing contracts that we have right now, and that's really all they can focus on. These nurses have about a 1 to 200 patient ratio, and they're in active contact with those patients on a regular basis to help improve their understanding of their disease, making sure that their care is coordinated between different specialties and practitioners and entities, and making sure that they have access to their medications. They remove barriers to care and are very, very active in helping those individuals.
Where does the interaction happen? Is this a home health model, or are they going into their homes? How do they get in touch?
This is telephonic,
okay.
By and large. However, when one of our clinics has 200 of these patients, we're beginning to pilot moving that nurse into the clinic with the job or the task, not of being just a clinic member and taking blood pressures on patients, but in fact being a very valued practitioner alongside of the doctors to help manage these complicated patients. And so we've already begun to do that.
And it's not telephonic in the sense of it's long distance telephonic.
Right.
The nurse from Boston that's calling to talk to you, it's the nurse from your local doctor's office who knows you, and they communicate that degree of connectivity with the primary care team, not just on the insurance company calling you about your health care.
Well, that's a key barrier, because a lot of the let's face it, failure of sort of nurse call center sort of disease management has been that that barrier that they don't know who they're talking to. And again, some other approaches are a little more reaching into the home. I mean, one of the things we've heard over and over again is really to manage these often very sick patients who may, dementia may be playing a role, their care structure, their environment, their access to food, right down to, are there trip hazards in their homes is a key. Do they have a ride to get to the primary care clinic? How are you, again, these are a lot of these, I know there's a social worker involved in here. How do you make sure that some of those barriers for the very most difficult patients are being looked at?
Well, the team does include a social worker, and we'll add social workers to this team because you're right. For example, access to medications or access to other resources often requires that kind of discipline. We actually have in the Baylor Healthcare System, and I think in Scott and White as well, we have even more detailed levels of interaction with patients. We have a group that takes care of nothing but end-of-life, advanced age frailty patients.
Yeah.
We have a group that has piloted and demonstrated great results with sending nurse practitioners into the home for the most complex heart failure patients. And so as we've looked at these various demonstrations of excellence, the trick is getting those funded. And because traditional fee-for-service generally doesn't pay for those. We've been paying for those out of our system revenues. And so this gets into the real conundrum of accountable care, and that is accountable care is a game changer. And if we're going to move into value-based payments, we're going to have access to the dollars that are in the general health care dollar in order to fund these kinds of innovations. And our payers are agreeing with that. And they for example, pay us for these nurse care coordinators.
And let me add to that. So one model that we have in place, we've had for 3 years, it was based on a grant we received, was funding for a transitional care model to focus on the frail elderly that had either heart failure or community-acquired pneumonia. And it was for individuals 65 years of age and older that fell into those two diagnostic groups. The funding was for a nurse practitioner to follow patients into the home if they met certain high-risk criteria. Otherwise, there was a registered nurse or a social worker that could follow them telephonically using the data analysis tool that we had before. But what we have really found with this group is that some of the other disciplines, such as a pharmacist, is absolutely crucial. So an example would be one patient that might be home with 35 medications ordered.
Right.
And it's not possible to manage that. They can't afford them. They have side effects from the medications. And so the value, I think, of all of the disciplines at the table overseeing that high-risk population makes a huge difference. Readmissions are 50% less than expected in the heart failure population followed in that model.
We've touched on this, but the informatics side, you talked about how many different EMR systems you're talking about. How does it all come together to make the data useful?
One of the things in the Quality Alliance that every member agrees to is everybody will have an electronic health record. But as we said previously, unfortunately, that happens to be multiple electronic health records. So if you start at the bottom there, we just finally are putting into place a health information exchange tool whose job is to connect some of these disparate health records. But the top two tools that are noted here are both analytic tools, and also the second one, Exploris, is a kind of a big data collection tool that literally both of those tools are able to absorb quality data from our clinical systems and cost data from billing systems and from claims. And so we ask our payers to give us those claims, because in fact claims become the total cost of care, or the way that you can see total cost of care. You can't see it from your own internal financial systems. You have to have access to claims to see the total cost. And so we insist upon that. Rosemary mentioned the tool 360 Fresh and Care Team Connect. 360 is a predictive modeling tool, and Care Team Connect is for the care coordinators to use. Both of those were recently purchased by advisory boards, so they have new names. This is an example of just a report that comes out of one of our systems, and hard to read but easily explained. Take the bottom central graph. That represents patients who have stage 2 hypertension, that is blood pressure greater than 160 and greater than 105, who are not on medication according to our records. Well, if I'm a practitioner represented in one of those green bars up and down, those are my patients who fall into that category. So we publish that list to our practitioners with the expectation you need to reach out to that population of patients. Those are people that are untreated or inadequately treated.
Is it blinded?
To the practitioner, no. It's blinded for others to use the data, but I can actually drill that down and publish his patients to him, which is perfectly compliant because they're his patients, and so that he knows that he needs to reach out to those 5 patients. They're not in compliance, and it's a huge quality opportunity for us to improve. So that's the way of getting population data into the hands of somebody that can do something about it. one of the things we do in the Alliance is we ask our doctors, this is a communication strategy, but it's also a quality strategy. We ask our doctors to come to our website. We have a secure website that they log in by password, and we actually ask them to come to that website a certain number of times a year in order to be eligible for quality payments or cost-effective payments. And so we've had very good participation with that. Each physician, and actually the same thing for our nursing homes and for our home health agencies, they all have report cards. This is kind of a sample report card where they're generally divided into 4 key areas. On the upper left is clinical integration. That is, how are you participating in our CI initiatives?
Right.
This year, part of the CI requirements is you got to view a webinar that has to do with clinical integration. Your quality scores are reported in the upper right-hand box, and those are specialty specific, defined by our specialists themselves. Okay, and then our service requirements, and these have to do with patient satisfaction surveying, which our independent doctors, many of them have not done in the past, but more and more it's necessary to do. And then finally, your own efficiency measures. That is, how do you, when you treat a certain condition, are your costs per case twice what your colleagues are?
Right.
And so they see their relative performance in this and can then change behaviors.
Well, and I'll ask the physicians on the panel this question because it's come up before. How do you, from a leadership, accountability, governance standpoint, keep those physicians accountable to this? Because it's an ACO, it could be in different groups. Who is the leader, the VPMA, the practice administrator, whoever makes the contact and says, Dr. So-and-so, you're not following the guidelines, or not confrontational, but here are the challenges that we have. Here's a plan to fix it.
I think, again, you work with your physician staff. Your goal is to make them better, okay? And you do have to have those type of discussions. Physicians are starved for data, okay? Meaningful data, let's put it that way. And you have if you have independent physicians, they haven't had this type of information before. Physicians are highly competitive, so when you show how they stack up against other physicians, then you catch their ear a great deal better. And I think all of those together, I think you can talk the evidence, you can show someone where they sit amongst their peers, and then you try to make them better. It's not a strong-armed approach in any way.
We've used similar kind of report, not this exact one within our employed group, and I agree with what Dr. Pringler is saying. Just giving the folks the data, initially you do it individually, you have that discussion, and they will universally argue that their patients are sicker than everybody else's, and that's why they're an outlier. And almost universally, you will see an improvement in the next quarter. And if they continue to be an outlier, then you talk about unblinding the data and sharing it with the group and getting a little bit more group pressure put on them. But we've been able to move physicians.
That seems like a nuclear option if you're going to open it up to their physician group.
We actually, we believe in our groups. Ultimately, I'd like to have all the data unblinded for the whole group.
In our employed physician group in the North, we began that journey 10 or 12 years ago.
Right.
And we started out with completely blinded data, respecting each person's individuality. And you could see your own scores, but nobody else's, or no one else could see your scores. And then we began to unblind it in local communities or local groups. And finally today it's totally unblinded. You can see if you're first or last in performance in any of these measures. One of the things about accountability, if you ask yourself, if I'm going to be in an accountable care organization, what am I accountable for?
Right.
And historically in the hospital environment, in the medical staff of most hospitals in the United States, when you sign your agreement to be part of a medical staff, you mostly are agreeing to try to practice high quality. I may be mistaken, and there may be newer agreements in some hospitals, but most doctors didn't join a medical staff agreeing to cost effectiveness. cost effectiveness is new. It's just begun to emerge in the last 5 or 6 years. And so the reality is, and also I didn't agree to clinically integrate. I agreed to do my thing well, but when I'm done with my part, it's not my responsibility. Well, clinical integration says that doesn't work. Patients' outcomes are often affected by their transition from one doctor to another, from the hospital to home, from the hospital to the nursing home. And so the whole idea of collaborative and a shared approach to these patients is kind of new. And in fact, an area that we haven't perfected it yet, but we're very committed to working on it.
The other committee but segment we talked about, and you just touched on it, but really this notion of how you start to get really the finance and compensation piece of it tied in.
As I mentioned earlier, all of our contracts with the Quality Alliance today are shared savings models. We know that we are going to be asked to take on financial risk, and so part of what Mr. Allison has asked us to do is to develop the capacity for risk management. I personally, when you've been a largely fee-for-service doctor and organization, believe that abrupt movement into risk can be catastrophic financially.
Right.
And so I sort of see it as a swimming pool that you wade into, but you don't dive in the deep end until you're ready. And so but nonetheless, to develop that capacity to manage patients' financial risk for patients that we take care of, and we are trying to do that. Today, it's more of a shared savings environment. We have been successful, as the middle of that shows, and as was earlier stated by Mr. Allison, we've had a positive financial performance against the employee benefit plan. But this has a lot to do then with how we deal with employers and with payers.
Right.
And so we today take care of 42,000 patients in the Quality Alliance. Next year we're going to take care of about 180,000 patients, so we're going to rapidly expand that. And these will all have shared savings opportunities. But I think Bob Pryor mentioned it earlier, the conundrum for healthcare systems and doctors is that as we fulfill the triple aim and lower the cost of care for our population, we will also lower utilization. And that means lower fee-for-service incomes. And so, again, the trajectory of how fast you engage in those contracts is important to maintain your own financial solvency today as you're moving into what will be a lower utilization. But the end game of this all, I think, for all of us should be value. And that is, if we deliver higher quality at lower cost, hopefully we'll attract market share and hopefully more patients to fill our capacity.
And so many of our physicians are really learning how to increase their panel size because of this need, and how to really approach care more in terms of a team-based model rather than the individual practitioner trying to care for all patients.
Well, in the process of that, and this is important, you're not just asking physicians to take on more volume of patients. Or in the process of this redesign, we're using words like efficiency, but ultimately it's how does that, let's take a primary care physician. How does he or she get through the day in a more efficient way? Are they using their time with patients to the top of their license? Are there things you can take off of them that someone else should be doing? Are there extenders or others that can help? Have you been able to, through this efficiency, sort of show them that vision, that it's just not about we're going to make you work like crazy and much harder to be part of this?
Well, we'll each take a shot at that.
Sure.
We're working on it.
Mm-hmm. Yeah.
The reality is team-based healthcare is for some physicians is hard because it involves entrusting to your colleagues who may be lesser trained than you some responsibilities, and that just that doesn't exactly fit with sometimes the way we've been trained, particularly if you're a little older physician. But it's important because otherwise we think that the efficiency is when everybody works at the top of his or her license. And so the utilization of physician, what are called medical assistants, nurses, nurse practitioners, and physician assistants, or mid-levels sometimes they're called, and then physicians themselves, each working at the top of his or her license, can take care of a much larger group of people and have better outcomes. So.
And we have some work going on now to really try to define and refine the role of the community health worker,
Right.
and what they can do to marry up with the certain demographics of a community.
We're also trying to use some IT technology to encourage patients not to necessarily come in with a face-to-face, but more an IT connectivity to the healthcare system, that they
Sure.
get their answers, their med refills, their simple things taken care of. So to answer your first question, I don't think we are there yet,
No
but
one is.
we are exploring all these other opportunities that will decompress the office environment just
Sure.
a little bit, either by expanding the team or giving them alternative ways to access care.
We've all had experience recently, or the last few years, management of anticoagulation with the drug Coumadin is tedious, and often the results are not what they should be. We found years ago that a carefully constructed protocol administered by nurses and medical assistants got better results than the doctors. The doctors
Right.
tend to tinker with it, and the medical assistants and nurses follow the protocol, and the results were far better. So today we turn that over to them completely. Better results.
But you really, and this is rose-colored glasses, but I firmly believe it, is if you give the physician the right tools to take care of the patients,
Right.
they'll do it. Help them do the right thing, and whether that's performing in a team. That's giving them information. But just to say, see more patients because you have to have a larger panel, and
Right.
that's not the right way to do it. So obviously we have to evolve into that. But I think in these teams, if we give everybody the proper resources to take care of these populations, they'll do the right thing.
Right.
And there'll never be enough doctors, and there'll never be enough nurses
Right.
to take care of populations. So the expansion of that, pharmacists, other disciplines, social workers, and even this community health worker idea, which is a much lesser trained person, are going to be important for population health.
And this, you talked about the shared savings, but you do have some transparency materials you share with them.
Yes, shared savings is, I guess you'd call it an incentive today for people to participate in these programs. In other words, there is a small financial reward, but shared savings is small in comparison to hospital incomes and physicians' incomes. It's just an incentive. But most of all, we see shared savings as a temporary phenomenon. If we're serious in driving costs out of the system, pretty soon you can't save much more when you get to a certain point. And it probably is simply it helps us to finance the journey to a movement to risk. Today we take care of about 40,000 patients, I think, that are illustrated there. And this next year, the Quality Alliance will expand that to large Medicare shared savings application and several more commercial contracts that'll all be constructed around the shared savings model. One of the things we're happy about, and Mr. Allison alluded to that a few minutes ago, is a significant drop in inpatient at 30-day readmissions. Readmissions, as most people look at them, are generally a sort of at least potentially a failure of process. And so the ability to have reduced that, we think, is substantial. And the next slide shows that we've actually had a drop in admissions per 1,000 patients, which again is extremely great from a population standpoint. From a pure fee-for-service standpoint, that's a drop in revenues.
Mm-hmm. Yeah.
And so but our system and our system leadership are committed to moving in this way, realizing that this is the direction we've got to go if we're going to achieve that triple aim: better health for the population, better patient experience, and at the lowest cost.
Have you charted what you want that number to look like going forward? Because I have run into executives. I met one even who is CFO of a health system and CEO of an ACO that is in many ways, balancing those two. I think that maybe there's some actual benefit to having someone sort of weighing both sides of it, because you have to be careful of not, one side throttling the other too fast. Do you have a stepped goal in mind for how you want that to look? Or is that just what's going to happen is what's going to happen based on clinical efficiency?
I think there are many things that will drive that trajectory.
Right.
If you think about it, and you see this in presentations all over the nation, everybody shows in their presentation somewhere a graph that shows falling fee-for-service reimbursements and rising value-based payments. Right. And at some point, every one of those graphs, the line crosses. Well, clearly there's a point at which that happens. How do you know where you are on that trajectory? Some of that, I think, depends on local market conditions. Some of it depends on your own performance. The local employer market, right. How ready are they for that? And so, but the issue is, clearly we are moving into value-based payment, and so in many ways we may be accelerating that journey for our local market, but one thing for sure is we don't want to play catch up.
Yeah.
So this is just a slide illustrating we're engaged with all of the health plans in our market, including our Scott and White health plan, and we're in a competitive and multi-payer environment, and we have great relationships with all of them, and they're working with us in movement to value.
And let's talk about this, because it's curious. We deal with a number of executives through our different programs, and I get to hear about all over the country. Describe the sort of local payers, because in some markets, obviously, it's very active, and not just the sort of traditional commercial payers, the health plans, but the large employers, who you're very close to direct contracting with a lot of them. What's the dialogue been like?
Roughly 75–80% of the Dallas-Fort Worth market is employer-funded health care. In other words, the employer is at risk. And for that 80% of our market, the payer is simply a third-party administrator. Right. So they're an intermediary. But ultimately, the employer bears. So the employer is looking at an organization like ours, and he says, okay, this preferred network does limit choice for my employees. It has, so you get into the issue of, is he, the employer, willing to change benefit design to incentivize the employee to buy that product and take this smaller preferred network of 3,700 doctors in our hospitals, and perhaps have lower co-pays, lower cost to the patient as well as to the employer. So they're balancing that against their own human resource needs, right, and their workforce needs. They all want to lower their costs, but am I willing to limit choice to get better cost and better clinical outcomes? And it's every one of them struggles with that. How's the
advent of the health insurance exchanges shifted that? Because it's getting to be toward a retail market where patients are having to make those same decisions. Do I want a lower, less choice for the savings I'm going to get?
Yeah, I think the employer responsibility, employee responsibility, or patient responsibility is rising today. The CalPERS study in California and other studies indicate that if the patient has a very specific financial incentive, they will engage around choices having to do with that. So.
Absolutely.
This is simply just illustrating our growth in population, but at the same time, I think we have capacity to handle the near 200,000 patients that we'll be taking care of this next year, and beyond that. And we'll expand the network if we need to take care of a larger number of patients. Mr. Allison challenged us all the other day that we may be taking care of several million patients.
So there's a few around. Let me flip it from a patient's perspective. And again, it's somewhat difficult sometimes when you're doing these things to understand what the patient sees out of it, gets out of it. But what's been the response so far?
You know, it's interesting. One of the good things, we participate in a thing called the Health Employer Exchange, and there's about 4 or 5 large healthcare systems who we all share the common phenomenon of taking care of our own employees.
Right.
And it's a great place to start because we have complete access to that financial data, to the claims, and we have complete access usually to electronic health records for the people that we take care of. And so it's a great way to see what levers you can push to improve quality and reduce costs and better clinically integrate. And so one of the things we feared with our own Baylor employees, this was before the merger, was that if we gave them a narrow network or a preferred network, they would see it as a narrow network and see it as a restriction. We get a lot of pushback. Turns out we didn't get much pushback at all. The employees in our particular plan are incentivized with lower copays if they stay in-network. And so we've had a steady increase in in-network utilization over the last 18 months. And yet the employee can go outside of network. He just pays more. So,
do you have the mechanisms? I mean, you talked about it from the physician perspective, but that, you know, from the patient perspective, that, you know, they're incentivized to, you know, get their annual screening, stay compliant with medication. If they're supposed to be on hypertensive medication, that they are. All those carrots are built in as well.
Well, we've had for many years a wellness program that it consists of some of those things you're talking about. If our Baylor employees in the North prior to the merger, and I think this will wind up being probably extended throughout the system, if they fill out a health risk assessment,
right,
and if they'll do a biometric screening, that they're rewarded financially for just having done that with a lower cost of their insurance. The thing that we've done this last year that I think is helpful is that data now needs to be completed or reviewed at a physician visit. So now suddenly my workplace information, which has been historically segregated, can become part of my ongoing care. And we think it'll give better outcomes long term in terms of developing care paths for the patient.
Well, we're getting very close to the end of our program, and I want to just sort of pose one final question. What's next? You know, you talked about you expecting this growth, significant growth in terms of membership over the next few years, but you know, in terms of the work you're doing to improve efficiency and quality, you've worked through some of, as you described, low-hanging fruit. What are some of the next big phases that you're going to go into, again, to get to that next level of improvement and efficiency?
I think more of the same, for sure. I think just knowing that we can confidently be able to both predict and manage the care of patients in terms of quality and cost throughout the continuum of care and be good at it is going to be very important. I also think that there's an element here. I mean, if we're really successful 5-10 years from now, we will have transformed healthcare. And because, as our two leaders said a minute ago, nobody can say they've achieved the triple aim. We can't say it either.
Right.
But that's definitely where we're moving. And if we do that, it will improve healthcare.
And I think a major move is access. And how do patients access a health professional? You know, whether it's with an app, whether it's at a drugstore. You know, as we see, the whole healthcare industry is changing, and how are we going to change, you know, with the needs of our population? And I think it'll be very interesting in the next 5 years to see where we go.
And we've got to come up with some more strategies on how to really engage the patients. You know, we talked about provider engagement, we talked about our staff engagement, how as a system we're going to do a better job.
Right.
We have to come up with some ways to really get the patients really engaged in their own responsibility in healthcare and the initiatives that they have to take to help augment what we're trying to do on the provider side.
Well, that's a whole other 3-hour discussion.
It is.
Well, I want to thank Baylor again for hosting us and for providing this wonderful program. And I think you're right. You talked about how this transforms healthcare. I think that Baylor's a wonderful test case because so many of the other health systems that you look at have other structures that and other challenges that may push things toward one way or the other. Again, thank you again for sharing that information. For those of you listening at home, if you do have any follow-up questions, by all means, my email address is on the screen. Shoot them to me, and sometimes questions are too specific that you don't want to ask them in a broad form like this. Happy to pass those on to our team at Baylor. Just a couple of quick notes about the follow-up to the program. You'll be receiving, within a couple days, you'll get a link to view to the downloaded program, so you'll be able to go back and view the video on demand and catch up on pieces that you missed, be able to see it again. It'll take us a couple days to get that up, but once it is, it'll be up for 30 days, and you can view the program that way. But with that, again, thank our host and Baylor for hosting us today, and we look forward to seeing you at our next program.